Hello and welcome to this podcast from the Coalition for Life Course Immunisation, the CLCI. My name is Gary Finnegan. I'm a health journalist and the editor of Vaccines Today. I'm also a trustee of the CLCI. This series looks at the vital role of life course immunisation in global health at a time of population ageing, climate change, geopolitical crises and rising healthcare costs. And today we're joined by Dr. Ben Kasstan-Dabush, who's a lecturer in global health policy at the University of Edinburgh and assistant professor of global health and development at the London School of Hygiene and Tropical Medicine. Hello, Ben. Welcome.
Hi, thanks so much.
Thanks so much for joining us. Let's jump right in. We talk so much on this podcast about life course immunisation, particularly, but from a global health perspective, how do you think the life course approach affects or relates to the sustainable development goals and even WHO level goals like the European Immunisation Agenda 2030?
Great question. But I think let's maybe just start by unpacking what we mean by life course immunization, because there's often not a lot of consensus about what this means, and people listening might come with different experiences or perspectives. I would say, like, at its most basic, it's allowing all people to benefit from recommended immunizations at every point in their lives. So not just vaccinating children, but also adults, allowing catch up if you miss those immunizations during the early years, but also, for example, at different stages when people might become pregnant or when they become older and more at risk of kind of severe illness from, say, influenza. But so that's one basic way. But I would say that also a life course immunization is infinitely more than that. It really starts before birth, right? Because vaccination during pregnancy enables passive immunity. It protects a baby before they're old enough to start their own schedule, let's say. So again, how do we want to conceptualize this? We could also take the HPV vaccine as receiving that during adolescence in order to protect you at a very different stage in life from cervical cancer. And then, of course, it could also be protecting you from, say, immune amnesia if you get measles, and preserving that kind of immune memory that you've built up over the time in your life course. So there's lots of ways of looking at this, but I think the practical question then is, how do we gear our services to enable these different ways of imagining immunization across the life course. So then, to kind of answer your question more directly about how does this link up to, say, the WHO agenda, it could be, for example, well, what supporting legislation or policies do we need to enable these different ways of imagining immunization across the life course? Like, what do we need in place to create the enabling environment for people to have those vaccines, whether that's, for example, thinking about our schools and education, what do we teach young people, the way that we integrate immunizations across our often very complex and fragmented healthcare services, right? And so that's one. And then if we think about the Sustainable Development Goals in that kind of more global health context, well, immunizations really underpin that incredibly important goal of good health and well-being, of preventing kind of deaths in newborns and children under the age of 5. Also, again, if we take HPV as an example of our focus on sexual and reproductive health care. So immunization across the life course, however we're imagining that, underpins and is very central to delivering on these broader kind of global health frameworks. I hope that goes
Okay.
some way in answering your
Yeah.
question.
No, absolutely. Yeah, and it was an important intro that you made on life course immunization because I wonder whether the concept of life course immunization is understood. You're maybe suggesting that it isn't understood in the exact same way everywhere, and perhaps in some places people don't think about vaccines outside of infant immunization, or they also think about older people and flu. But as you said, there seems to be, if I'm not mistaken, a bit of a push globally on things like cervical cancer, on HPV-related cancers. Is that something you think is growing slowly or maybe growing unevenly in global health conversations?
I think it's more of I'm trying to think of the right word of a dissonance actually, because we'll see that life course immunization very explicit in these WHO kind of policy guidelines and implementation guidance, but actually it doesn't always filter through to the language of everyday public health messaging. And in the UK where I'm based, it's actually quite rare to see public messages and educational campaigns around the idea of a life course, that this is for kind of lifelong health as much as we can aspire to, that we offer this at a particular moment to kind of protect you later in life when that risk might increase or become apparent, or present itself. So I think that there is something of a dissonance, and I've often wondered what opportunities could there be if we actually kind of raise our communities in the knowledge of what life course means, and what the benefits of that are, so that we don't have this striking gap between routine immunization in children to possibly kind of pregnancy, if that's your decision in life, or when you get older and you become more vulnerable to the risks of influenza.
Okay, and I suppose sometimes I think about the difference globally, between maybe more advanced policies in European countries compared to others, and then within Europe there seem to be quite big differences across the continent. But maybe one of the interesting things you're touching upon is that within a developed country like the UK, there are sort of communities where this concept is not well explained, or the community hasn't been engaged in the idea of vaccination beyond infancy. How do we overcome that with communities that maybe are a bit underserved in this respect?
Um, Great question. I think it's really about co-developing those approaches together with the communities. Those are often the experts of kind of lived experience, to work with them to share responsibility for health protection and for the health, and of course, of their own communities. So I think like there are ways to build educational curricula, even around sensitive subjects, or vaccines that may raise sensitivities for particular communities. Again, thinking about the HPV. And so it's really kind of thinking, well, how do we share that responsibility? How do we kind of build those partnerships? How do we sustain them? And I think, unfortunately, we can take a high income country setting like the UK and see that it's not immune to austerity and cuts in investment that are so critical, to making immunization across the life course, a possibility. Those tailoring of services, those kind of co-production activities, which tend to be, more expensive. You could look at it as a cost on the one hand, or an investment in health protection, but again, not immune to austerity and the consequences of that.
Which often, as you know better than me, impact some more than others. Austerity doesn't sort of cut equally. But is there anything that we learned from the COVID-19 pandemic about engaging communities, or even having champions, local leaders, religious community leadership? Is there anything positive that's come from that experience that has carried on, or are the positive things that happened just left in the past and we've all gone back to how we were before the pandemic?
The COVID-19 pandemic showed us many things. What can be achieved when immunization programs actually receive fit for purpose funding, right? When they're actually prioritized, you can achieve incredible things. The COVID pandemic was also, holding us up a mirror of the state of our public health infrastructures, and how they weren't ready for this kind of once in a generation public health emergency. So it does show many kind of lessons to learn from, I think, and how we really need to kind of cultivate that trust with communities, build that confidence, enable that equitable access now to get the routine program right in order to get us to a point of actual preparedness for when that challenge comes around again, which inevitably it will when we think of the challenges that we face around climate breakdown, for example.
And so, what are the main factors that shape vaccine decisions, especially in marginalized communities where, in some cases, there are pockets of susceptibility? Is there anyone or any programs within the UK or any other countries you've seen who are doing it well? So, two-parter. So, what is shaping the decisions, and how should this be responded to?
Well, in some ways, the decisions aren't that different to what general society might be faced with. For example, that convenience and access, the ability to have a timely appointment at a time that's flexible for you with all the other priorities and constraints that you might be having to deal with. We know, for example, at this moment, kind of there are all kinds of capacity issues on primary care, which raise kind of practical kind of implications in access, but also, again, in that austere environment, the ability to receive vaccines in different spaces. For example, those, thinking particularly around Sure Start Children's Centres where you might go and where vaccines can be offered, or at the very least discussed in a broader commitment to your family's health and well-being, places that you might already be going because you've got children. And so there are those kinds of practical, I think, issues. And then I think there are also the differences in engagement. If you've not gone through the same school system, the kind of education that you've received, the way that you're primed to think about immunity and immunizations might be different. And hence, the way that you go about engaging with communities will also need to be different and tailored as well. So I think it's a combination of issues. I think we're also, of course, living in a time where misinformation is prolific, and the risks of that are everywhere, from social media to the highest political echelons of the United States of America. So these are challenging times that require, I think, a commitment and an investment to really working in partnership with the communities that we're trying to serve. That is, of course, the ultimate goal of any immunization service is to serve community health.
And do you think, I remember it could be 10 years ago, but there was a tailoring immunization programs document from the WHO, and some really interesting examples about um, not just marginalized groups, but even like anthroposophic school systems, those Waldorf schools, um, Roma communities for sure, and really interesting one amongst some Jewish communities in London, where they actually so they presumed maybe there's a religious element to it, but when they went and asked them, it's going back to what you said earlier. It was really about having to get a bus with 7 kids, you know, and so they redesigned it with the communities. But that was probably 10 years ago. Do you think this idea is mainstreamed yet into program design?
Unfortunately not. I mean, the tailoring immunization program study that you're referring to was actually one of the first piloted in North London's Haredi community because of
Yeah.
this persistent issue of under immunization and vulnerability to preventable disease outbreaks. And you're right; that kind of clarified some of the issues around access, the challenges. And let me tell you, if you've ever sat in a clinic where you've got families coming in with 5 to 7 under-immunized children and how kind of chaotic a waiting room can come, and actually what it means to think about access in that particular setting becomes very palpable. I think, unfortunately, the TIP study didn't assign responsibility for implementing recommendations and measuring progress and accountability over that, um, which hampers that long-term application, I think, of the recommendations. So that was one. And then I think, unfortunately, which is always the most tragic, is just the recurring way we see the same problems and limitations of short-term funding and commissioning cycles that enable you to kind of make a slight improvement in your immunization coverage, the way that you engage, try something new, see how it works. That funding stops, and then that attrition begins again. And that's the most kind of depressing thing about TIP that I have seen, is just that we've actually got documented proof and evidence of what the challenges are and what the enablers are, but the ability to kind of sustain that strategy just isn't enabled by the way that public health seems to work.
it's super frustrating, unfortunately. Every so often you get this burst of optimism where you think now people know what to do, and then yeah, through various for funding reasons or whatever, it doesn't quite catch on momentum
Well,
wise.
yeah, and then I think it's a reminder to us that actually, we often talk about the cultures of communities and underserved communities, but public health operates in its own culture
Mm.
entirely, and that's where we see that kind of conflict between the two.
One of the things we always end up coming back to on this podcast and in any conversation about vaccination and vaccine uptake is trust. Is there anything from your own research that maybe would inform, how can we build trust in all communities? Like, is there kind of a, a guidebook or anything that could be followed? Um, because it seems like everyone knows the era of a top-down, just trust us messaging systems not doing so great. But what is the alternative, or what is the better way to do it?
Well, I think that, that top-down approach, to use your words, it probably will work for the vast majority of the population, that
Mm,
vaccination as routine, particularly, if families have 1 to 2 children, which is more the norm. I think it's, communities with different needs, larger families, where you probably need a complementary approach. And it's learning from them, that engagement work of, what will help to build confidence, in the recommendations or the services, if indeed that's the primary issue that we're talking about, right? And that could look on several levels. Again, we can take, England as an example, that actually there's not a standard nationwide vaccine confidence training package for healthcare providers, right? So
okay.
we know that nurses will have to go through kind of annual update training, but there's nothing kind of comparable for confidence. And similarly, those people who are just as crucial, your administrators who are doing the calling and the recalling and the invitations, also no standard kind of communication, no training, sorry, in confidence. Um, and that needs addressing, right? So when you're as I get to do, and it's a real privilege of doing interviews with families, communities, but also healthcare providers, and when people with those big responsibilities, which of course they are, they're the first point of call in the immunization journey, are saying, we need more training in how to do this confidently. We need to listen to them, and we need to kind of work on that. And I don't think the UK or England is unique in that regard. I think it's a global issue.
Yeah.
And then again, I think when it comes to the community side of understanding what works, just to give you an example, I was doing an interview with an Orthodox Jewish healthcare worker, healthcare practitioner, and she was saying how she'll often get called into the nurse's office if a mum is a bit reluctant to offer or to accept all the vaccines that she's being offered, or if she's passing through the waiting room and hearing mums talking about, well, should we do this one? Should we not do this one? And how she'll intervene. And I thought, well, if this is a trusted voice from within that community, and serving that community, how could we work with this? So we developed a kind of script around exactly what she was seeing in the consultation room, the questions being asked, and we recorded her voice in conversation with a mum. And the hope will be to screen this in kind of clinics as patients register at a GP surgery, as in nurseries, and then we developed that to produce kind of like booklets, called like a Heimischer guide to vaccination. So kind of using a Yiddish word of what is maybe um, relatable to you, and we hope that these might help to kind of address those questions in a way and a language or a voice that's familiar to them. And I don't think that's unique to the Orthodox Jewish example. I think that's probably an approach that could be tried across the board. It's just having the funding and the partnerships in place to do this. And of course, it's never clear to me who is responsible for this engagement work, who is responsible for funding this engagement work. It's engagement often falls through the cracks of, is it primary care, is it public health, whose responsibility is it?
Hmm. And it's interesting, you talk about nurses and other admin staff, pharmacists too. I think people who often
Absolutely.
want to do, like with the best will in the world, would like to do it, but they're also people who have 80 jobs. Like if we were talking about diabetes or cardiac care, we'd say, oh, practice nurses should do more, or GPs should do more. But yeah, they all say they need the skills. But do you think that medical anthropology and social sciences is more accepted now than 10 years ago, or further back? Do you find a growing acceptance to the role? And maybe what is the role of that sort of side of the equation?
There's probably no consensus among kind of medical anthropologists of what the work that they do, and you do have kind of differences between those who are maybe more applied and more critically applied, or more critical or theoretical. So I think at the very least it's understanding the various forces, structural, political, economic, social, cultural, that come together in our health and our well-being and our biology. And I think that there is a growing recognition of what that brings to the table, that particular kind of community embedded vantage point, that ability to kind of reconcile differences, differences in what it means to kind of protect life and protect health, and how can we work together and bridge that difference. And I think there's been various ways that we've seen that role kind of valued. Ebola, for example, COVID-19 pandemic. Um, but again, it's, those opportunities to sustain the collaborations. And it's been really interesting as an anthropologist to spend so much time in primary care, and to understand, you know, actually how could we work together more effectively, in order to again meet that goal of serving community health. But it's very often funding dependent. It often comes back to that.
And do you find it, is there acceptance from fellow professionals for the role of medical anthropologists?
Professionals being,
Sorry, other health professionals. I mean, other people in the primary care system, nurses, doctors, others.
I think, yes. For example, I've certainly kind of been in clinics where nurses have really appreciated having somebody talk to kind of community, patients from the community coming in at their level and understanding, and kind of brokering that, asking questions that maybe nurses might not feel comfortable to ask themselves. Um, and then at other times, there's probably been um, a difficulty for them in accepting some of the critical feedback and reflection that can come with this role. Again, when there's a preference to see the issues very much on the side of the community, and not as a relationship between the two, or an issue in the relationship between the two.
Okay.
But generally, those healthcare professionals who are also more engaged with the world of research probably appreciate it. I
Okay.
think.
And sort of looking ahead a bit and thinking about some of your own research in this area, and colleagues' research, um, do you see sort of a strengthened role for social sciences and community-based research in life course immunization projects? So not just infant, but you mentioned pregnancy, for example, and later life too.
I would really, really like to, because I think, again, it's that kind of critically applied perspective of how can we embed and integrate a life course immunization perspective in people's lives, and understanding, well, what do people's lives look like? How do communities operate in order to integrate that approach? So I think that there's huge potential. For these collaborations, and value in that. It's just, again, I think it goes back to, the enabling environment for these relationships to happen, and allow that kind of, collaboration to be born and be sustained over time.
And finally, then, is there anything in particular that you're working on at the moment that you think would be of interest to people working in the immunization area generally, especially when it comes to equity and marginalized, underserved communities?
Sure. With kind of funding from the British Medical Association Foundation for Medical Research, myself and colleagues Tracy Chandler and Tassine Khan are looking at a study of vaccine delay. So we know in communities like Orthodox Jewish families, vaccine delay might be common. Obviously, that means that children are then sitting ducks for passing infections. And what we want to do is try to understand, well, actually, how can we pivot that towards acceptance to schedule? Understanding, what works, what are the prompts, what are the enablers, what happens when we look, very often when we look at kind of primary care, it's quite it's a system, but it's also fragmented, and each one might be working in their own rhythms and with whatever resources they've got. But to understand, well, when you've got primary care teams in different parts of the country serving linked communities, how might consistency help? What might happen if we channel consistent messages across them? So that we know, for example, that there'll be travel, there'll be exchanges, there'll be marriage, there'll be kind of going to schools and whatever across these different areas. The communities are very much linked. So what happens if we try channeling a consistent joined up message? Might that help? What happens if we take a practice in one area of the country and apply it in another one? Might that bring the same benefit, and just reduce those barriers and kind of iron out that relationship wherever possible? So that's what we're looking at, and yeah, hope to share results. We're still kind of collecting fieldwork, but hope to doing fieldwork and collecting data, but hope to share those results soon.
Okay, sounds fascinating. Thanks very much. Keep us posted when that happens. But we'll leave it there for the moment. And thank you so much, Ben, for taking the time to join us at busy spell, as always. Best of luck with the research. And thanks to everyone who listened and watched. Don't forget to subscribe to the channel. You can look at previous episodes in the videos playlist. And if you subscribe, you'll get the next video as soon as it's uploaded. But for now, thank you all very much, and goodbye.